Hello and welcome to the EGP Learning Podcast with Andy and Gandhi.
Hi, I'm Andy Foster, a doctor in Nottingham, GP partner of 7 years, one of the directors of NCGPA, which is a federation operating in Nottingham, and ONSEC of RCGP, Vale of Trent faculty. So I suppose that those are my declarations of interest for today. Gandhi, tell us about yourself.
Yeah, so I'm Hussain Gandhi. I'm a GP partner and trainer in Nottingham as well. I'm the owner of EGP Learning, as well as an RCGP faculty member like Andy, and I'm the former chair of the Vale of Trent faculty. I'm also GP Survival Treasurer, as well as the owner of something called System 1 Facebook user group, which some of you may be aware of. I'm an avid gamer and geek as well, on top of all the other billion hats I tend to wear.
Wow, long list. I'm in esteemed company here with you, Gandhi. You need to lengthen my list, I think.
Well, I'm not sure about that. Sometimes having less hats is a better thing, particularly with kids. We've created this podcast to try and talk about some of the things that interest us. We're both Nottingham-based GPs that have a fairly good passion for technology and the use of that, particularly in primary care. So we wanted to try and share that love that we have, and also see if it can be useful to other people out there. So
yeah, absolutely. I suppose I would add to my intro that my interests are, I'm interested in general practice working at scale. Hence the interest in the federation, and how technology can help patients in general practice deliver better care.
Cool. So one of the ways that we wanted to structure this podcast, so just to give you a heads up on what's coming up, we thought it'd be useful covering some of the new kind of technology advances, particularly things like apps and that kind of stuff that are relevant to healthcare and particularly primary care. And then after that, we were going to cover some of the new kind of news updates and stuff, again, around that similar topic. And then after that, we hope to interview a regular person to get their perspective in terms of what they experience with primary care and technology and all that kind of stuff. And for our first interview, we'll be talking to Andy himself.
Yeah, for me, very very convenient since I'm here already. But yeah, we hope to have some good guests lined up for you in the weeks to come and months.
Cool. So, talking about apps, so we had a look at what's out and about at the moment, and one of the best places to actually look for that kind of information is the NICE updates. Particularly, we've come across a couple that were quite useful and I think worth sharing.
Yeah, so NICE have been providing app reviews and evaluations for some time, and most recently in November they published some guidance and reviews of 2 new apps. So we thought we'd have a look at those today. One of them is Sleepio, and the other is an app for helping communication between prospective mothers with gestational diabetes and the teams looking after them. So I think we'll talk about Sleepio first, shall we, Gandhi?
Yeah, so Sleepio is originally a website, and as with most websites, they've gone and created an app to kind of use it. It's designed as something to help people with poor sleep, which, I think is applicable to most people in healthcare nowadays, let alone the patients.
Yeah, very true. So the NICE guidance describes Sleepio as a product designed for adults with poor sleep to help improve their sleep through cognitive behavioural therapy approach. So this is an example of some digital CBT delivered by an app-based system. Yeah.
So it works by the looks of it quite well. It's got quite a good feel, very simple to use, very similar to, I guess, other kind of mindful-based apps. So we talked about Headspace earlier as being an alternative kind of visual version of this app. I think one of the other powerful things about this is the website and then the knowledge that's behind it in terms of accessing CBT for insomnia, which is actually probably one of the most useful things in terms of helping people with poor sleep.
Yeah, I was going to say, Gandhi, I know that you've had an opportunity to use the web-based version of this application. I was just wondering how you found it.
Yeah, so I had a baby girl a few months back, and as most expectant parents, suffering with poor sleep at the time. So I just wanted to see, is there actually some sensible advice about how I can get some better sleeping habits as a result of dealing with waking up every couple of hours with the missus to look after our daughter and stuff. And so I had a look at Sleepio. Their website has a free function in terms of you just log on with an email address, and it asks you some simple questions to quantify and qualify the type of sleep problems you're having. As a result of that, it then gives you personalised helpful tips and things. And then there's the option, obviously, to go for the more fuller package, which is the CBT for insomnia side of it afterwards. Admittedly, that I haven't tried personally because other things took over, but it does look very attractive, and actually access to that particular resource I think would be really useful.
Gandhi, can you remember any of the specific personalised advice that it gave you about your sleep?
So there was the standard kind of sleep hygiene stuff that I think we talk about with a lot with the patients and things. So, making sure that you're ready to go to sleep when you want to go to sleep, trying to obviously reduce screen time, that kind of stuff. Particularly with the little one, I guess the key thing it said was about trying to alternate, who's getting up and things. So simple advice, but sometimes actually it's easy to forget. Trying to make sure that you're not staying upright, so when you are going back to sleep you just literally get back in bed, lie down, that kind of thing. And fair enough, my individual example probably isn't the easiest one, because it's probably the more you sleep is a problem because of external factors, shall we say. But some of the theory behind it, some of this, the advice behind it was very sound, I found, and particularly the way it assessed how your sleep is affected, I think was really useful.
Yeah, because I'm just reading the technology review, and it says that it links to a Fitbit, for example, or other sorts of activity tracking devices that you might wear at night. Is that how you used it?
So I didn't at the time, because I think that's only with the app that works more effectively. However, at the same time, I was tracking my sleep with my own little Fitbit that I've got, and it pretty much racked up in terms of I was waking up several times a day. That matched with the advice, and what it showed me was that I wasn't really getting into those deeper layers of REM sleep. And actually, what I noticed afterwards, when I tried to make a few of those simple changes, and also not waking up as often because we were sharing the workload and that kind of thing, it meant that I was getting more periods of better quality sleep. It was better. By no means it was 9 hours solid. Wasn't never going to expect that, to be fair. But you know what, I felt a bit better and I was able to still function.
Okay, good, interesting. So just looking at what they're actually offering, it looks like the intervention, they offer the monitoring with and feedback, some biofeedback about your sleep, linking to a Fitbit or other suitable devices are available. And then the intervention seems to be 6 weekly interactive 20-minute electronic CBT sessions. So that's interesting. And I guess we should talk about the costs.
Yeah, so Sleepio doesn't come without a cost. So the evaluation part is free. Simply all you have to do is give them your email address, really. But if you wanted to go for the more the actual CBT for insomnia, there's a cost. It's £200 per year, which may sound like a little bit of a mouthful to swallow, really. But I guess one of the things to remember, if you compare that to other interventions that are used for helping patients with sleep, so compared to most medications, they can be of similar cost. Bearing in mind that obviously medications come with a big downside of dependency, side effects, and interactions and stuff. Yeah,
and they're things that I'm reluctant to do as a GP.
Yeah,
I think I would be much less reluctant to recommend an app, so that's a plus point. Just comparing with the cost of CBT, so £200 per year for the app intervention, and again referring to the NICE document, 6 55-minute CBT sessions, which they consider would be the standard therapy, would cost about £600, so significantly cheaper than that. Yeah, so.
And I guess that's also based on the accessibility, because actually the challenge for most places is having access to CBT for insomnia. Because, so for example, if you take our Nottingham area, there isn't a contained CBT for insomnia clinic locally. That is potentially packaged as part of the IAP services that a lot of places may have, but as an independent resource, it's not really something that's everywhere.
It doesn't really exist in Nottingham CBT for insomnia. Very good point. And I suppose even where it does exist, patients are going to have to wait to use it, whereas they can hop straight in with an app, which is good. Yeah. So what was the evidence behind the effectiveness of this, Gandhi?
So I think when we looked at it, it showed that those patients that they put on the waiting list, so basically no intervention whatsoever, far superior in terms of effect and outcomes. It showed that a lot of people that had tried it were having better quality sleep. There isn't unfortunately many many evidence trials or anything like that compare it against directly CBT for insomnia clinics and that kind of thing. So that's obviously something worth looking at and seeing if that does change. But I guess the key thing for me with this is the accessibility. It is an alternative that can be used, and I guess with that comes the power and the resource that comes with it.
Yeah, and it's also quite patient empowering, I think. It's quite patient directed. It's using their own technology, their own phones. They're taking the initiative to download the app and sign up. So I think you get a lot of patient buy-in with it, I imagine, which contributes to the chances of success. Just noticing that the benefits were maintained at 3-month follow-up as well in the study, which is good.
Yeah, which is definitely better than most medication options as well.
Very true. Very true. Yeah. So very interesting. App, something that we could all download and try, particularly the evaluation period without signing up to pay money if sleep's not a particular problem for you at the moment, and something that can be recommended safely to patients as it's recommended by NICE. So yeah, fantastic. So Gander, you've used it partially. Is this something that you would personally recommend?
So I do already. I think that the website portion of it, I definitely recommend to my patients. Working in St Anne's, it's a deprived area. Admittedly, most patients do not have £200 to jump up. So, admittedly, I say to them, look, whether you go for that, completely your choice. But at the very least, the assessment portion, I'm a big fan of. I think it is more targeted sleep hygiene advice for those patients with chronic insomnia issues. So I think that's better than, just a generic, go to bed early, watch your smartphone kind of thing, and it's just that slightly more specific information.
Yeah.
Whether they go for the more expensive option of paying for the service, I think it's got good groundings. I think access to CBT for insomnia is a key issue for particularly healthcare delivery. And I guess like I said, if you rack this compared to other alternatives, it is actually cheaper. There is the option of commissioners, I guess, to look at this as a provision mechanism for patients and stuff. And if you compare it, £200 is the full price. I know that on the NICE update it does talk about the fact that some areas have actually commissioned this for patients at a much cheaper rate overall because they're bulk buying, obviously. So there may be some headway in terms of CCGs looking at this as a potential option for improving access to healthcare.
Yeah, excellent point. Okay, so that was one of the apps that we looked at this week. So what was the other app, Gandhi?
So the other app that we looked at is called GDM Healthcare. So GDM stands for gestational diabetes. And it's an app that basically looks at monitoring and the patient feedback in terms of gestational diabetes itself. Andy, you've had a look at this in a bit more detail. So do you want to talk us through it?
Yeah, so it's described as an application designed for people with gestational diabetes to allow for remote monitoring of blood glucose levels and communication with healthcare professionals. So essentially this is a mobile phone app that communicates with wearable blood glucose monitors and communicates the information from those monitors directly to the teams of people looking after them, so to the doctors and midwives looking after their gestational diabetes. And the main intended benefits are really those of compliance with monitoring and prompt communication to teams at hospital. And I think the hope is, and some of the indications are, that it will reduce the need to attend quite so many hospital appointments and nurse appointments to monitor and care for their gestational diabetes.
Okay, so I guess any information on how patients found it, or the experience of using this kind of app?
Yeah, so the NICE website does cite a few studies into the app. It's worth recognising that these normally contain quite low numbers of patients, and they generally have been done for sort of research and development purposes of the meters and the product. Nevertheless, they do show really quite good evidence of patient compliance. And also excellent feedback from patients in terms of their usability. So what they're finding is that people generally continue to use the device for the duration of their pregnancy, and that they report that it's easy to use. Also, good usability feedback from those teams of people receiving and using the data at the hospital.
And how did it rack in terms of things like cost and all those lovely bits that the commissioners and stuff may be more interested in?
Yeah, so NICE site that this was evaluated by 4 NHS trusts, in particular Oxford University Hospitals Foundation Trust, and they found that they were calculating a saving of £230 per patient per pregnancy. Mm-hmm. So I think the cost of the service worked out at about £370, and they were finding that they were achieving a reduction of 230. So saving costs, not considerable, but I suppose the main benefits would come in terms of compliance with monitoring and freeing up those staff who would be taking readings and seeing these patients to deal with the roles.
And I guess the other side of it is it means the patients aren't having to come to clinics. There's the cost saving of not needing to run the clinics, but also for the patients themselves having to take time out of their day to come just to basically have a chat about whether it needs upping, down, and I guess that can be done via, some form of telemonitoring, which is basically what this app is. Yeah, that's true. So the app does have a facility to send information back to the patient to give them instructions about their medication usage. Even better. Which is great. Okay. So it sounds like a positive thing. In terms of, I guess, if people were interested in using this for their patients, how viable is that? Well, it seems to just be available in certain centres at the moment, and with certain compatible glucose monitors. If you download the app, you do need a specially issued QR code to activate and begin to use the app. So I think it's one of those things that we'd perhaps like to see rolled out more in the future. I would also add that I think it perhaps needs a bit more evaluation. It seems like this would be beneficial, but those studies that were evaluated were quite small, and so there's the possibility of this study effect where people in small studies in specialist centres often comply more with treatment than the general population. So I think that needs looking into a bit more, but certainly one to watch. Definitely. Yeah, be interested to see what other implantable or mobile monitoring devices are brought to market, and what apps evolve for those systems to use that data and communicate with the hospital. Really exciting area to look at, I think. Yeah, I think one of the things that I quite like about this particular one is that it can use existing appliances and paraphernalia that's already kind of around. I mean, if you compare this, I guess, to one of the newer products on the market, the Libre healthcare one for diabetic patients, so the implantable, BM glucose machine, that seems really positive in the way that it may work, but quite expensive when you're talking something like £50 per unit, and each unit can only last up to about 2 weeks. I think for patient empowerment, it seems like a great tool. It does have this sheer cost evaluation issues, whereas this, it's kind of using what people are already using, just giving them that ability to transmit that data. I mean, it's the basis of telehealthcare, isn't it, in a sense? It sounds like it may be a really positive thing. It kind of sounds like it's one for the commissioners to take up rather than the individual practices and things. I think so. Yeah, excellent. So I guess those were the two most recent NICE app evaluations. What's your feeling about the NICE app evaluations in general? Have you enjoyed looking at those? Yeah, I think they give quite good summaries. I mean, NICE, as we know, is kind of like our national organisation for looking at the evidence behind what we use, and I think that they're very good and detailed in terms of their evaluations of these products. I think whether we can look at other options and stuff, definitely, but it's a good place to start, I think, and we both of us, I think, have actually been surprised at the depth of information that they've been able to provide on these two apps and stuff. I think it's really, really rigorous. They include some considerations of the technology, the usage and user experience. They find relevant literature and provide references for that literature, and do reach some conclusions and recommendations. So I've been really impressed reading these reviews. Okay, so now we want to move over to some news updates, if that's all right. So we've had a couple of news stories that have come out. Yeah, so Gandhi, the first one is something that, I think it's caught all of our attention, but this particularly caught your attention, and we've had some conversations about it offline and with other people. But so Gandhi, what's the recent story that's really captured your attention? Yeah, so I think that the hottest kind of like tech healthcare story for us, particularly in primary care, has been the GP at Hand. So this is the app that's been backed up by the Babylon Healthcare Company. A pilot that's being run in London at the moment, and it kind of integrates that whole concept of being able to Skype with your doctor, really. So use the app, you have to register with the GP at Hand practice. So there's an actual practice based in London, which is doing this, and then based on that you can input your symptoms and then be able to have an appointment with a GP through the app itself. Even if needs be, they can actually book you in face-to-face, but the predominant nature of this is using the app itself, and then you've got your appointment. So again, this has been, so that sounds
very convenient, putting a patient perspective in Hatton, but this has been quite controversial. So where has the controversy come from with this story?
So I think the big controversy about this has been the fact that when you actually look at the exclusions that the company have put behind this, there's quite a few patients that they recommend may not be able to use it. So let's be clear, they don't say that you can't use it. They just suggest that these patients may not benefit from the actual service and should potentially stay with a more regular GP. And I guess the controversy around that is that a lot of people are seeing this as cherry-picking patients, and as a result of those exclusions, they're pretty much seeing the working well. But generally speaking, are the patients that have the lowest need and lowest in terms of use of the services. And therefore, when it comes to funding, it means that they're able to run a more lucrative service and leave the more complex and challenging patients for other practices to manage, which actually can significantly impact the amount of services that you can put on.
So I'm gonna ask to dive a little bit deeper on this one, Gary.
Okay.
So I'm imagining our listeners out there, and some of them are experienced GP partners, but some of them will be trainees. Some of them might not work in general practice, might not work in medicine, might even be patients. So just explain what the danger is here to their kind of ordinary GP practice that they might be quite fond of or enjoy using.
Yeah, so the worry with this is that the GP practices that are left to manage these more complex patients are basically seeing those more complex ones, having to have more appointments to look after their health needs, having to invest more money in services to look after them, but then not being able to have the balance of the funding to actually, equate this, and therefore the problem is that pushes more complex care to particular practices. They then find it more difficult, and as a result of that, they're not able to maintain financial sustainability. Potentially, worst case means they have to shut. Yeah,
absolutely. It is quite scary, actually. I mean, the way I look at it is, as GPs, we get about £150 per patient per year to provide care. It varies, and that comes from a few different sources. But that's for every patient. So that's regardless of whether they're a young, fit 20-something or whether they're becoming slightly more frail, crumbly, elderly person with multiple comorbidities and complex needs. It's the same amount. And the way general practice is able to provide care for everybody is that effectively the payments you get for those patients who have pretty low health needs effectively subsidise and provide the funding that the GP needs to go and do multiple home visits to the frail elderly people. So if all of those young fit people are registered with, say, GP at hand and take their £150 per year over to them, you're left with £150 per year, without being subsidised by other patients to care for your frailer, more vulnerable patients, and it's not going to be enough money. So
no, it's not.
The fear is that if the fit well people walk to these online based services, then the system will not be able to have enough money to care effectively for frail and vulnerable people, and that's really worrying. It
is worrying, and this has become such a big concern that actually this issue went to the LMC conference. So for our listeners that may not be aware of this, every area has what we call local medical committees. The closest thing to a union, I guess, that you can describe for GPs. And they're all based around local regions, and then every year they have an annual meeting to try and decide what the key pertinent issues are for general practice and to give direction to the GPC, our negotiating body, in terms of what should be the contractual issues that they work at to make general practice work better, both for patients and for practices. And this was such a pertinent issue that this was included as a last-minute motion, and it was pretty much unanimously voted that this needs to be tackled at the highest echelons of the NHS and the primary care and stuff, because it is genuinely viewed as a worrying shift in the way that healthcare is commissioned. But also, this has potential huge impacts for patients. If you don't have access to the correct services, that means you may not get the healthcare that you deserve, really.
So Gandhi, what if anything has been happening as the dust has been settling on this story?
So it's quieted down a little bit. I think it's, like I said, it's been kicked up to the commissioners and the people higher up to discuss about how viable this is. It's still running at the moment. It's still a service that's running up in London. Down in London. I keep forgetting we're north up here. And as a result of that, I think it's definitely a watch this space kind of thing. It's only been running it's coming up to just about a month, so it's not long. We'll probably see some changes, I imagine. Interestingly, as a principle, accessing your GP on your smartphone and stuff, I think there is potentially some legs with that. We're seeing an increased use of telehealth care and certain services like teledermatology particularly really lend itself to this kind of model. The question is can you deliver complex primary care through this model is the question, and I think that's the part that we haven't quite been able to bottom out really, and that's the worry I think a lot of experienced GPs and a lot of areas are having, that can you actually deliver the full gamut of primary care through a smartphone? Probably not really.
Yeah, and I would agree this is a story where the underlying technology I think certainly has legs. I think in a few years' time we'll probably all be familiar with using triage apps on our mobile phone and probably communicating with GPs via Skype or video link. But I think it's just the implementation that's worried people, and that not enough thought's been given to how this might destabilise the underlying model of primary care. So certainly one to watch and see how this develops. And this might segue into nicely into another story that's been in the news. So Babylon have been in the news quite a lot. And Gandhi, what's the other story where Babylon have been in the news?
Yeah, so this other story is about the fact that Babylon, the parent company of GP to Hand, have been commissioned to do actually this pilot, although I don't think they're calling it pilot. I'll come back to you, Andy, to give the full thing, but basically it's not gone the way I think they were hoping and they've had to stop. So do you want to explain, Andy?
So I think it was in the news maybe 6 or 9 months ago. It was announced that Babylon were going to, North West London CCGs, I think it was, were going to pit Babylon Health Symptom Checker app, bit of a mouthful, against 111 call handlers in a trial to see if their app can provide better use of resources really and reduce inappropriate referrals to A&E and GP services. And they were doing some initial focus group and small scale testing. It's a bit unclear exactly what they were up to, but they found that patients were gaming the system. I think those are the words that they used actually. So one imagines that they were perhaps deliberately answering questions in a certain way, but they were gaming the system as to achieve quicker access to GP appointments. I think it was really, really interesting, and for me, through opened up a whole sort of gamut of questions. I was really wondering why that is. So Gandhi, how do you feel about this?
Well, I think it's an interesting prospect. I mean, technology has, I think, huge power for helping in primary care, but I think it has to be respected in terms of the way that it's used. Using technology to act as your triage system, potentially, can have some really good uses, I think, and it's definitely an area to watch. I mean, we keep hearing how AI will take over healthcare and we won't need your doctor and that kind of stuff. I think we're many years off from that, and I think this is a great example as to why, because you can break the system, and that's effectively what has happened. And it's definitely an area to keep an eye on, but I think we're well away from that place of it being effective.
Yeah, so I've got a confession to make, I guess.
Okay.
It's 9 months ago when I first heard about this story. Whilst I'm excited about technology, there was a part of me that sort of hoped that this might not go too well.
Okay.
Just to tease that apart, I guess it's part of feeling threatened as a professional and as a human being.
Yeah, definitely.
Feeling that my role, might be under question and might be able to be done by a machine. So part of me sort of hopes that maybe this might not work or that we weren't ready for it yet. But it failed for the reason I didn't see it coming. I didn't think that patients would deliberately game the system. I thought that they would have the risk balance in the wrong place, and that's why they wouldn't achieve a reduction in A&E attendances. Or I thought something else would go wrong. So it's really interesting that it didn't work for those reasons.
Yeah, maybe this unfortunately is a marker of the wider issues in primary care. We know for a fact that general practice is massively under-resourced in order to cope with the demands that are placed upon it. And, part of this may be, a wake-up call to the powers that be that actually, patients are willing to and able to find loopholes around systems they try and put in to try and prevent these problems from happening. So actually, is that a wider context issue of the provision that's being given to them and the way that it's commissioned? And
maybe we shouldn't be too surprised, as those GPs listening out there will know that every now and again you tweak your appointment system, you make a change to try and improve access and make better use of the resources you've got. And often things seem to work for a while, and then patients adapt because they need to see their GP and they want to see their GP and their practice nurses, and they find a way to adapt to the system, and you normally return to the status quo where you still don't have enough appointments to satisfy the demand. I had a few thoughts as to why this went wrong, and I think number one, I think they're trying to solve the wrong problem in a way, or they're using a tool which addresses access and makes access easier for patients. You've got your phone in your pocket, you can use that any time that you like to check your symptoms. So they're trying to solve an access problem. So I think they're trying to solve the wrong problem. So the problem that they're trying to solve is a capacity problem. We all know that there aren't enough GPs, there aren't enough practice nurses to meet the demand of patients, and patients get frustrated. But I think they're using a tool that addresses access to try and solve that demand problem. So actually using an app, it makes it more accessible to get access to an assessment and potentially see a GP, but it doesn't change the fact that there aren't enough GPs there.
Yeah, so I think you've got to be careful, Andy. You're probably going into the basis of the constant general practice argument about access versus capacity and the fact that they are completely different viewpoints. I don't think we've got enough time to tease that one.
Well, maybe not. But that's one of the thoughts I had.
Yeah.
Two, I think it's easier to lie to a machine than it is to a person.
Definitely.
And I think that's one of the things that our receptionists and the human beings sort of bring to the game, really, in terms of people feel probably more guilty if they're not being truthful with a real person. And I think that's actually an asset that we perhaps underestimated here. And three, I'd like to see a more collaborative approach and perhaps more collaborative language from some of these AI companies and perhaps the industry. There's a lot of talk about replacing people's jobs, replacing people, and you don't need a doctor to do this, you don't need a nurse to do that. And I think actually a lot of the research coming out of the AI field is that humans are better at some things, apps and AI and technology is better at other things, but actually the best results are achieved where those two things work together.
Definitely.
So if you look at the field of chess, computers are better at playing chess than humans, and now they'll always beat humans playing chess. But what's the most effective combination? It's actually humans and computers working together. And there'll be a computer working on its own, or a team of computers, and there'll be a team of humans working on chess problems. So it's interesting. So I think we need to maybe join forces with technology, get some people back in the loop to work with the technology, and maybe that's how we'll achieve better outcomes.
I think it'll be a watch and wait as usual.
Absolutely.
Cool.
What's next, Gandhi?
So what's next? Well, actually, this is the segment where we would normally interview somebody, and today that somebody is actually our esteemed Andy Foster.
That's true. Not sure about esteemed, but I am present and willing to be interviewed. So so here I am, Gandhi. Fire away.
So Andy, I know a lot of your history. I mean, we've been working together for coming up nearly 5-6 years now. But why don't you tell us about, I know you mentioned you're a GP in Nottingham, but a little bit more around that. I mean, what particular roles have you enjoyed the most?
Yeah, sure. So I'm a GP partner in Nottingham, working what I suppose you describe as a fairly deprived area up in North Nottingham, and I've been a partner there for just coming up to 7 years now, so that's quite a while, I guess. As I mentioned in my earlier interview, my areas of interest tend to be in GPs working together at scale. Very interested in what we can achieve together, and that we can possibly achieve more together than we can achieve alone. And that's led to me being involved with Nottingham City General Practice Alliance, which is a federation of 47 local practices covering a population of 330,000 patients. So that's something that takes a fair bit of my time these days. Also, always had an interest in technology, ever from my school days, like yourself. I enjoy playing computer games every now and again, the occasional board game as well. So more recently I've been trying to bring that sort of love and interest of technology into general practice, and say trying to do some things with technology at my own practice, and also bringing that into my work at the Federation. The final thing, well not final, but another thing that I'm involved with is the local RCGP faculty. Really enjoy being involved with them since my return to Nottingham 7 years ago after VTS in Birmingham. And that's been a lot of fun as well. Enjoyed being involved and then becoming involved in the organisation of the faculty and bringing in some of the technology interests to that as well.
And that's actually how we met. Our first time that we came across each other was at one of the faculty-run events. So tell us a little bit more how you got involved with the faculty.
So, as I alluded to, I went to Nottingham Medical School and then did some house jobs around Nottingham and Lincolnshire and then thought I need to go somewhere else. I must broaden my horizons. So I went all the way to Birmingham. So not really that far at all.
Not really.
But it was a different city. And did my VTS in Birmingham and had a great time and made some new friends there, but felt, no, I think my life is more Nottingham based. So I decided to come back to Nottingham in 2010 and found that whilst I had lots of connections in Nottingham, most of them weren't in general practice. A lot of my colleagues from medical school were doing other specialities. So I thought, I need to get connected. Okay. So I saw some adverts for what was then called the Nottingham UGP group. I think they were only just beginning to adopt this First Five brand to these sorts of groups. And got involved with them and got involved in organising some events and that's led to being invited to a faculty board meeting, as often happens to most people. It's a common way to faculties, get a tap on the shoulder, come to a meeting, and really enjoyed meeting really interesting GPs, switched on, positive GPs and GPs from all sorts of different roles across the patch. In education roles, in partnership roles, all sorts of different things. And I suppose that's where it began. Okay,
so we heard about how you got involved with the faculty, but what are you doing with the faculty at the moment then?
Okay, so currently I'm the ONSEG at the Vale of Trent faculty, which is quite an exciting position actually. And one of the main responsibilities I seem to have inherited somehow is running the annual AIT Leavers event. I think these events happen up and down the country and it's an opportunity to prepare AITs in their ST3 year and First 5 GPs as well for life after work. So I've been leading that event for the last 2 years and it's been a great opportunity to bring in some of my other interests for that. Sometimes you just need a platform to indulge other things that you've always wanted to do, or that you like. And Gandhi's nodding here as well. So we've played with the format and introduced a few innovations there.
And these are innovations that actually have been nominated for awards.
So we were nominated for a Faculty Innovation Award this year. Missed out to Jamie Hines and his from the Midlands faculty and their Describe GP in 150 words exercise, which is actually fantastic. Real fan of that project. But what we did was we tried to get the most out of the AIT Leavers event, and last year we introduced what we call GP Speed Jobs Dating, which was the AIT event is great because there's roughly 70 plus young GPs who don't currently have jobs in one place. And we recognise this and we thought, we've got all these people in one place, and on the other hand, other faculty stakeholders are the partners of the practices who are really crying out for young GPs to recruit, to get on their Rolodex to use as locums or to recruit into salaried or even partnership roles. And we thought, how can we serve these two communities? And it seems obvious with hindsight, doesn't it? But we thought, let's connect them and get them together. And then we thought, what's the best format to do that? Well, okay, speed dating's perhaps been overtaken by dating apps and websites, but it's still got some presence in popular culture. And thought, okay, let's use a speed dating format. That's probably the best way to maximise the number of contacts when you get all those people in the same room. So that was a very interesting innovation.
It was. I mean, obviously we worked together on that kind of project, and one of the things I found most rewarding about it was the fact that we achieved local retention of GPs, which is something that's hard. Let's face it, getting GPs to stick around is not easy enough. But then we know that from last year's event and this year's event, we've actually had practices come back to us saying we've actually found staff from this event, and we've been able to keep local GPs. I think there's real value in that. What more can be said really on that particular topic? But that wasn't the only innovation we've been doing.
Yes, that's true. So this year we thought we need to wring the maximum amount of value from this event that we can. So we sort of threw everything in the kitchen sink at it, really. So we thought, okay, we've got we've got the AITs there, we've got the practices there, we've got some experienced speakers there giving information. In fact, wouldn't it be great if more people could potentially be involved? People who could, AITs or first fives who couldn't be there. So what we did was we used some of the video and website expertise within the faculty team, and we got some cheap mobile phones, and tripods and microphones, and we recorded many of the talks that were given on the day. We produced a website using free tools and hosted those videos afterwards so that people could relive the day, or those that couldn't be there could experience the knowledge within the talks.
Yep.
Gandhi, tell us about the 360-degree camera.
Yeah, so I think that was the other innovation we took. So we wanted to give it the most immersive experience possible, and we are at the dawn of 360 video technology really ballooning. And we thought, why not go for it? So we actually videoed most of the main talks, the plenary talk, the talks about revalidation and appraisal, a key discussion topic for many GPs, not just the newly qualified. And we basically filmed it in 360 so that when you watch it, it's as close to being there as actually being there as you can actually get. And I think it is something that we really found useful. The feedback we got from people that then were able to watch it online was that actually this is quite cool, but at the same time it's got value in terms of the information it's giving.
So I think it's a good opportunity to plug the website that we set up for that. So the website is www.valeoftrent.org.uk, and that's where you can still see a blog post about the story of the day, how we filmed things, what equipment we used, how much equipment that cost, and also see videos of the talks and the 360-degree videos we talked about. Oh, and the final thing to mention is having all these people in one place and the cameras. We thought we'll try and create a promotional video for the Vale of Trent area as well. So we got a number of people doing pieces to camera and edited that together in what's quite a nice video about why be a GP, why be a GP in the Vale of Trent area, and that's also available to watch at www.valeoftrent.org.uk.
And if we're speaking about websites, it may be worth talking about one of the ones that you run yourself. You've been running a blog, I believe.
Oh, right. Oh, yes. That's interesting. So, yes, I've been running a blog since last summer.
So why did you start it off?
Okay, well, it all started when I went to a leadership course in 2015, run by East Midlands Leadership Academy. We might be able to put their website in the footnotes, I guess, because they run some good courses and they can be free if you remember local LMC here in the East Midlands. And part of that course was connecting yourself with who you were before medical school and kind of, what were your interests before. This happens to many of us. Interests get sidelined as you go through medical training. And so I remember being quite interested actually in art and quite enjoying sketching as a youngster. Interested in computer games, technology, computer programming to some extent, and also in business in a way. I remember selling revision sheets in the schoolyard and things like that, sort of enterprising young lad. And actually, a lot of these things lend themselves quite well to general practice anyway, and maybe the reasons why I ended up where I was within medicine. Also, I enjoy reading blogs, tended to like technology blogs, also interested in personal productivity. Get interested in some random things, don't we?
Yeah.
And I thought, having got that experience on the course, I think I want to start a blog. I think that would be a great way to indulge some of these things from my past, make them relevant for what I'm doing now as a GP. What I create may be of interest, maybe of relevance to other people. And I thought the whole thing would just be fun and be a nice sort of hobby and in some ways a distraction from the day job whilst being something productive to do. So that's how I got into it. And it's had a good response. I'm going to give you the address now. So
go for it.
www.avoidingpuddles.com. So Dr. Foster, there's a nursery rhyme that involved puddles. That's where that came from. If anybody thought that sounded like a strange URL, that comes from the nursery rhyme.
And I guess as a fellow blogger, I mean, I've always been a big fan of the work that you've done with that particular blog. I have to admit, one of my favourite articles is still the one that focuses on Pokemon Go.
Oh, right, yes.
So it's a while back, and for our listeners, they may remember, Pokemon Go when it ballooned out onto the network. This is the, using geolocation to try and find things, and the method that can interact with getting you active and that kind of stuff, and the gamification side of how that works. And I remember you talked about how potentially we could use gamification in primary care to improve, activity, to improve engagement with, chronic disease management, that kind of stuff. And I found that a really interesting take on how it can be used.
I'm glad you enjoyed that article, Gandhi. It's good. There's almost a whole segment podcast on all of the implications, of augmented reality, location-aware apps, gamification. There's lots of potential, I think. Interesting.
Yeah, maybe something for us to cover on a later session.
I think so.
Cool. And then your final thing that I know has been very close to your heart is you work with the Alliance and stuff, and particularly the past couple of years. I know you've been heavily invested in it. How did you get involved with it, and what are you currently doing?
Yeah, so Nottingham City General Practice Alliance is really our local GP federation here in Nottingham City. It was incorporated, so there's many ways that you can structure these things. It's structured as a limited liability company owned entirely by the GP practices that form its membership. They are the only shareholders. And really the idea behind forming the company was, it came from this, I think, from a place of fear and from a place of optimism, if I'm being honest. A few years back, there was a lot of talk of private industry moving into primary care. It seems to have died away a little bit now, or to some extent. But people were really scared that the private sector was going to move in and take over. So I think part of the reason that drew people together was a defensive one, in a way. And I remember talking about ringing the wagons and things like that, which is interesting. If you imagine cowboys with their wagons kind of pulled together and the Indians attacking them. I remember we had a picture of that when we were pitching, actually, which was interesting. Okay. But it also comes from a place of ambition as well, I think.
Sure.
Because GP practices are notoriously, well, not notoriously, but they have been traditionally small organisations. And in a world where medical care is becoming much more complicated, you can only achieve so much as a small organisation before you need to start to have people who are subspecialised, before those benefits you can get from just operating at scale in terms of buying power, having dedicated teams of people focused on certain activities. So there's lots of opportunities for general practice working at scale. So I think it really came from those two places. Practically, the CCG kindly actually facilitated the very beginning of this by organising some meetings of interested GPs. And I know Gandhi was involved in the setup process quite closely as well. And of those GPs involved, a group, including Gandhi, went on to develop the concept, sell that concept to the 47 practices who eventually became members, and ultimately we were incorporated, and then a board of directors was elected, and I was fortunate enough to be one of those elected, and that's how I got there.
So that's how it was formed and things. And I know that it's had a few interesting challenges to come its way. And I mean, I think probably the less we talk about the PCPO, the better.
Yes, don't mention those words. Yes.
Yeah, but let's talk about, I guess, the future. There's particularly a couple of projects I know you've been working on that sound really interesting, and potentially from our listeners' viewpoints, not just locally but nationally, quite useful. So let's hear about those.
Yeah, so I guess the first thing I'll talk about is something that I've been quite closely involved in, and it's been quite interesting for me as a personal journey. So I'm sure everybody's heard of active reception signposting, one of the top 10 impactful things that practices and GPs can focus on to improve their productivity. Features in
as recommended by NHS England in its 10-point plan for improving healthcare in primary care.
That's what I was trying to allude to. It's also part of the GP Forward View, and Health Education England provided guidelines for those people who want to train their receptionists. So this is something that has become a national strategic priority. Also something that many practices have been doing for a long time. I suppose at its heart it's about receptionists understanding the patient need and why they're contacting the practice, and where relevant and for appropriate patients, making sure that they understand their options in terms of other services they can use that might be quicker and provide a more direct route to treating their symptoms than the GP appointment that they may have felt they needed.
Okay.
So what happened next? Well, we knew that there was a need to provide this training in Nottingham, and in fact, the funding was available that can only be spent on this, so it was going to happen.
Okay.
So it was something that was going to happen anyway. So at the Federation, we decided that we would like to develop the training and the things that were necessary to support that training.
So how is this different to reception-based triage, which is obviously a more tricky area to go into?
Yeah. So the important thing about this is getting it right, doing it safely, and actually having something that you're able to deliver and train all receptionists to do.
Okay.
So reception triage. So triage is quite a technical. It's quite a technical activity. So there are triage systems that are used, like the Manchester triage system, which are quite complicated to do and involve following an algorithm and serial questions following an algorithm, and they can be time consuming, and they can result in sort of defensive outcomes in terms of managing risk in a defensive way. So reception signposting is completely different. It's really about solving that informational problem. So the problem that is being addressed is that in response to demand often outstripping supply in terms of access to healthcare, commissioners have commissioned many community-based services which patients can often access directly. For example, in Nottingham, patients can access physio services directly and IAPS, counselling services, without the need to see their GP or contact their GP's surgery. But patients don't always know about this. In fact, patients often do not know about this. And there are many appointments that I've had where patients come in, I talk about their problem, and all I do is hand them a piece of paper with a telephone number on. So there were resources being wasted, and also patients' time not being used effectively as well. So active signposting is about using that first point of contact with the practice, which is often when they speak to the GP receptionist at the desk on the telephone. Of course, some patients book appointments online, but they're still in the minority. And at that point when they call, the receptionist sensitively asking what the problem is, making an understanding of that problem within the context of what they know about the patient, and where appropriate, providing them with information about where they might find out about how to look after themselves, information about what services might be relevant for them, but very much allowing that patient to choose and not acting as a barrier to GP appointments, but acting and providing information about services. And we are finding that patients are choosing, alternatives, and it is having an impact on service usage, which is good.
Cool. I mean, it definitely has that value, I think, in comparison to, like you said, reception-based triage, which I've come across in certain practices when I used to locum. I always found it a little bit uncomfortable, I think, with that prospect, because, trying to act as a block when you're not clinically trained. I mean that's where potentially one of these root problems with 111 and maybe even, the Babylon system come into play is trying to not use that clinical inference and reasoning process when you're trying to, handle the flow of where a patient goes and things. So it sounds really interesting, I have to admit. And I know in our practice it's been, really well received. I think the staff in particular got really behind this kind of idea of being able to help the patients and signpost them to the correct thing, but at the same time not feeling the pressure of saying, actually, you can't use this particular option because you should be using this. I think that's one of the key messages that they've had with this as well.
Yeah, that's very nice to hear, Gandhi. Another thing I would add, which is just interesting as to how we went about this, because we took quite a entrepreneurial approach to it, I guess. So I was quite impressed with the team at NCGPA, because one of the interesting things about doing this with NCGPA was that we wanted to do something quickly, and we wanted to make efficient use of resources. So it was really interesting to be speaking in terms of getting a minimum viable product up quickly, MVP. We were also quite efficient in terms of how we generated the artwork. So a lot of it is cannibalized from my blog and repurposed, which people will be able to see if they look at both of those websites. So it was really refreshing to move at a fair pace and with a fair amount of freedom, which you don't always feel when you're trying to be innovative in other NHS structures. So that was really interesting, and so that's one of the things I've really enjoyed about federation work.
Well, I think we're going to finish off at that point. So we'd like to thank all of you for listening to us. We would like to invite you to comment. So we're actually going to be posting this on a system called SoundCloud. From that, you'll be able to log on, listen, hopefully, and as well as that, make any comments and feedback. We'd love to hear your questions, queries, that kind of stuff, and also things you may think would be worth us covering. In addition to that, we're hoping, as we said, to have some further people that we can interview. Prospectively, we've got Dr. Kenny Livingston joining us next month. He's the current creator and owner of an app called ZoomDoc. Completely different to Babylon's, GP at hand, I might point out. But it provides a really interesting take on using technology to access a GP service. So definitely worth, I think, tuning in for next week.
Yeah, fantastic. And I would add, I don't think we'll go too long without Gandhi escaping being interviewed as well. So we'll turn the mic on Gandhi in one of the upcoming
We'll see if we can avoid that for as long as possible. But up until then, thank you for listening. I'm Hussein Gandhi.
Yeah, and thanks for listening. I'm Andy Foster.
See you later. Bye.
Bye.